Hello, I'm Shabana this side, your friend and colleague, and today I'll be discussing about manual vacuum aspiration, that is MVA, and this is also one of the types of surgical management of miscarriage, and this is done in the outpatient department under local anesthetic. And so in the MRCOG Part 3 exam, there can be a station where you will be asked to teach your junior about manual vacuum aspiration. So again, I have tried to keep it as simple as possible. So let's have a look. MVA procedure, that is manual vacuum aspiration procedure, it can be performed in an outpatient setting under local anesthesia. For example, in a treatment room in an early pregnancy assessment unit. What are the advantages? It reduces the patient waiting time for surgery and cost of hospital stay, so it is very cost effective. It avoids the complications of the general anesthesia. And coming to this MVA syringe, this is made of latex-free plastic. It can be single-walled or double-walled, and double-walled syringe is the new version, and that is used more frequently. So here you can see this is the double-walled syringe. The volume is 60 ml, and it creates a vacuum of 610 to 660 millimeter of mercury, similar to that generated by an electric vacuum machine. There are the cannula. So you can see these are the cannula which are color coded. These are 24 centimeter long. These are color coded according to their diameter, which ranges from 4 millimeter to 12 millimeter. So this is the maximum diameter. This is the 12 millimeter. You can see it is indicated here. Size of the cannula is chosen according to the period of gestation and the estimated size of the uterus. So if the period of gestation is 6 millimeter, then the size of the cannula will be period of gestation is 6 weeks. So size of the cannula is going to be 6 millimeter. It has graduations with 6 marking dots starting at 6 centimeter from the tip and spaced 1 centimeter apart. So you can see these are the marking dots. Okay. 1, 2, 3, 4, 5, 6. Okay. 6 marking dots are here. And these are all placed 1 centimeter apart. Now this cannula, this is flexible and the tips are rounded. The rounded tips minimizes the injury to the uterus. With the rounded tips, there is less risk of uterine perforation. What are the prerequisites before performing the MVA procedure? So we have to take written informed consent from the woman. Cervical preparation is done with the prostaglandin E1, that is misoprostol, 2 to 3 hours prior to the procedure, before termination of pregnancy or miscarriage, particularly in women with a tightly closed cervix. Some surgeons prefer to dilate the cervix by starting with a smaller cannula and increasing the diameter until it is possible to insert the required size cannula. Misoprostol can be taken sublingually, orally, or vaginally 2 to 3 hours prior to the procedure. This makes the cervix softer and easier to dilate with the plastic Karman cannula, thereby avoiding the use of a metal dilator. Regarding the pain relief, before the procedure, women is offered tablet naproxen or tablet brufen. It is given orally 1 hour before the procedure. And if women has any contraindication to non-steroidals, then paracetamol and or codeine can be given. Regarding the baseline observations, pulse, blood pressure, and temperature are checked upon admission. Then patient is asked to empty her bladder just before the procedure. She is asked to lie down in a lithotomy position. She is cleaned and draped. Bimanual examination is done. Size and position of the uterus and cervix are assessed. Regarding the procedure itself, first we have to keep ready. The syringe has to be made ready. How? MVA syringe is charged, that is, a vacuum is created by pressing the distal walls of the syringe until they click into the locking position. So these are the distal walls. First, we are going to lock them. After that, the plunger is pulled backwards to generate a vacuum until it locks. First thing is lock these distal valves, press them and lock them, pull the plunger backwards to generate a vacuum. After that, we are going to visualize the cervix with Cusco speculum. Cervix is cleaned with antiseptic solution. Then it is infiltrated with a local anesthetic. If needed, cervical block is performed. Anterior lip of the cervix is held with a tenaculum or a valsalum. An appropriately sized cannula is introduced into the uterus. If required, the cervical os is gently dilated with a rounded tip of cannula, or Hager dilators can be used. Then charged syringe is attached to the cannula. After the syringe is fixed, the proximal valves on either side of the syringe are released and the syringe is moved in a rotating motion. Okay, so first we are going to press these distal valves, lock them, create a vacuum by pulling the plunger backwards, and then we are going to insert the cannula in the uterus through the cervix. Once the cannula is inserted, then this charged syringe is attached to the cannula. After that, the proximal valves, these are released and the syringe is moved in a rotating motion. Then intrauterine contents are aspirated via the cannula into the syringe. When syringe is about 80% full with products of conception, it is detached from the cannula. Contents of syringe are emptied into a bowl or a kidney tray. Syringe is charged again, that is, vacuum is created again and reattached to the cannula. The process is repeated until the uterine cavity is empty. At the end of the procedure, all the products of conception is inspected and sent for histopathological examination. If the procedure went well and patient is stable, she is allowed to go home within 1 or 2 hours after the completion of the procedure. So, in the outpatient department, the procedure room has to be equipped with emergency resuscitation equipments, including IV cannulae, IV fluids, adrenaline, oxygen, atropine, misoprostol, and a defibrillator to handle common medical emergencies. And to reduce the unexpected emergencies, there has to be careful selection of low-risk women for the procedure. What about the selection criteria? Right now, there is no consensus in the literature regarding the selection criteria, but following criteria are used by some. And that is for MVA, the woman has to be hemodynamically stable. Paris woman who is well motivated, nulliparous women who can tolerate speculum examination, ultrasound diagnosis of early fetal demise with crown rump length of less than 25 millimeter, ultrasound diagnosis of an incomplete miscarriage with retained products of conception less than 5 centimeter. No clinical signs of infection, no fever, no offensive discharge, or no generalized lower abdominal pain. Women who are not suitable for outpatient MVA include those with more than 10-week period of gestation, panic attacks, cervical stenosis, fibroid uterus more than 12 weeks in size, uterine malformation, hemorrhagic disorder, and treatment with anticoagulants, allergy or contraindication to the use of misoprostol, or if there is allergy or contraindications to local anesthetic agents, if there is postnatal retained products, uterine infection, inability to tolerate pelvic examination, and if retained products of conception are more than 5 centimeter. Regarding the complications, yes, there is some risk of complications, like there is risk of pain, vasovagal collapse, uterine and cervical injury, uterine perforation, incomplete evacuation, pelvic infection. Now, regarding the risk of injury, the injury risk is very less in expert hands. Regarding the NICE guideline on the management of miscarriage, it recommends that when clinically indicated, women should be offered the choice of MVA in the outpatient setting because it is considered as a safe and effective choice for women requiring surgical management of miscarriage. and it is quite effective. Quite cost effective, and it is done in the outpatient department under local anesthetic. And if everything goes on well, women can go home within few hours. So this is all about the MVA. Again, I have tried to keep it as simple as possible. Hope this was helpful. I'll be uploading more videos from the examination point of view. Please do like and subscribe to my channel. And thank you. All the best. Take care. Bye-bye.